Good morning, everyone. I'm Dr. Jack Ludmere. I'm the EVP of Equity and Community Engagement here at the level of Associate Provost. It is really an honor for me to welcome all of you to our 5th annual Jefferson Salutes Martin Luther King Jr.'s vision. I want to acknowledge the presence of Jefferson trustees, our president and CEO, Dr. Steve Klasko, I just saw him, Jefferson leadership, community leaders, and our invited speaker, Professor Dana Bowen Matthew. The preparation of an event like this requires significant planning, and I want to thank Ms. Sabrina Harris, our Senior Director for Diversity and Inclusion, for her incredible work to make this occasion special. Thanks, Sabrina. In our beloved city of Philadelphia, 60,000 children go hungry. A third of the population is obese, and 40% of our children live in poverty. Our infant and maternal mortality are one of the highest in the nation, similar to the ones I've witnessed in lower income countries, demonstrating enormous health disparities affecting in particular African Americans. This is a tragedy. Of all the forms of inequality, injustice in healthcare is the most shocking and inhumane. Reverend King gave these words over 50 years ago during the Second Medical Committee for Human Rights to address discrimination in the treatment received by African Americans. Yet, the inequality remains. We must end this injustice. To paraphrase again Reverend Dr. King, our lives begin to end the day we become silent about things that matter. Understanding unconscious bias, striving for cultural competent care, integrating equity into policy, funding, and programs will help narrow these gaps, whether in rural, suburban, or urban communities. We have the opportunity to change inequities in our own city. Jefferson has launched the Philadelphia Collaborative for Health Equity to address the social determinants that contribute to health disparities for so many communities in our city. Together, we can bring the vision of life. We want to be a catalyst for change by listening to our communities, building trust, enabling multiple stakeholders to address the community concerns. We can make a real difference in Philadelphia. We can become active participants of a brighter future for us and our citizens, so we can make reality Reverend Dr. King's dream. Now, I would like to introduce an icon at Jefferson, in our city, and in our country. Dr. Edith Mitchell, clinical professor of medicine and medical oncology at the Sidney Kimmel Medical College, a pioneer in addressing health disparities in cancer, and the past president of the National Medical Association. Dr. Mitchell.
Thank you so much, Dr. Ludmere. It's always a pleasure to serve with you, and welcome this morning to our program on the celebration of Dr. Martin Luther King. It is my privilege to introduce our guest speaker today, and I am really thrilled to do so. Dr. Dana Bowen Matthew. I have had the privilege of working with Dr. Matthew on the National Medical Association's Montague Cobb NMA Health Institute, where we are addressing the healthcare disparities that we observe in this country. And I can tell you, Dr. Matthew is a lawyer, but she knows her stuff in medicine. She has worked with us addressing healthcare disparities with the National Medical Association, and she is one of the world's greatest experts on health policy. Not only that, so she has worked with lots of doctors. Not only that, her husband Thomas is a cardiovascular surgeon. So she's with doctors all the time. But let me tell you about her. Professor Matthews is currently the William L. Matheson and Robert M. Morgenthau Distinguished Professor of Law, F. Palmer Weber Research Institute, and Professor of Civil Liberties and Human Rights Professors of Health Sciences at the University of Virginia. Dr. Matthews is an author, and she has led the conversation in this country for years on public health, focusing on racial disparities in healthcare. She is the author of the book, Just Medicine, A Cure for Racial Inequality in American Healthcare. In 2013, Professor Matthews helped to establish the Colorado Health Equity Project, and in 2015, served as the senior advisor to the director of the Office of Civil Rights for the EPA. During 2015-16, she was a Robert Wood Johnson Foundation Health Policy Fellow in residence in Washington, D.C., and pivoted her work toward population-level clients. Her background, Professor Matthew graduated from Harvard Radcliffe with an AB in economics, later earning her JD from the University of Virginia and her PhD from the University of Colorado at Denver. And these accolades only scratch the surface on her history, her expertise, and her contributions to healthcare and health policy in this country. So join me in a great big Jefferson welcome, Dr. Dana Bowen Matthew. Thank you so much. What a pleasure. I'm so thankful for that introduction. I wish my kids were here to hear it. I do appreciate the intonation in your voice during the introduction. She is a lawyer. But don't run from the room quite yet. Please listen to her anyway. So I've been told I have about 15 minutes to just set the conversation. I follow, in this illustrious event, a list of people that I have to say I'm intimidated by. I mean, your last speaker was Andrew Young, really. So I appreciate that you've had me. I am going to talk about Just Medicine. If you've read any portion of the book, what I'm going to do is spend maybe 2 minutes on the book, because as I talked about earlier, my ideas have evolved since the book. And they've departed from some of the more individualized ideas that I came up with during that book. And I've got another book coming out that I want you to read also. So I'm going to explore some of those ideas with you. This book is called Just Medicine. The next book is called Just Health. And its message is that just medicine depends on you. So I'm trying it out on you. Let me know how it works. So I'm going to talk about Just Medicine, what it is, why Just Medicine depends on you, and what I ask you to do after you leave this room. So first I'll start with Just Medicine. I am a lawyer, so I have to start with the law. And if I'm too loud, maybe turn me down a little bit. I hear a lot of myself. The difference between the medicine we have and the medicine that would be just,
I'm going to posit to you has lots to do with the law. It has lots to do with the 13th Amendment. That's where I'll start. So by a show of hands, how many already know what the 13th Amendment says, right? 13th Amendment emancipated slaves in slave-holding states, right? That's what it did. Here's why just medicine depends on law. That was not the original 13th Amendment. So the original 13th Amendment, if you sit in my constitutional law class, I teach you, did the exact opposite, right? And so that's the language that I have up there. The original 13th Amendment made it impossible to amend the Constitution to require states not to hold slaves. So it constitutionalized slavery, right? Now this would be see, somebody's mad. This would be just a historical nicety if it wasn't for these facts. Number one, not only was this the first 13th Amendment, but it passed both the House of Representatives and the Senate of the United States with the requisite 2/3 vote. Number two, after it passed, it went on to ratification by 6 states and would have had to go through the process. I don't know if it would have been ratified or not. But number three, President Lincoln, our great emancipator, spoke about this version of the 13th Amendment with approbation in his second inaugural address. Right. So why do I start there? I want to start there to let you know that justice in medicine requires a change in the law. And it will require collaboration between you, healthcare providers, students, clinicians, and me and my professional community, the law, right? It can't be done alone. So what the original 13th Amendment did was it reflected the ambivalence that we have in the United States of America about racial equality. And so that ambivalence being brought forward resulted in legal protection for the kind of discrimination that you see here. Now, this is a 1942 sign. It comes from any community. You could have seen it in Detroit, in Philadelphia, in New York, anywhere, right? Where it was this kind of discrimination that produced segregation, residential segregation, right? But it had to have the legal environment in order to do so, right? And that kind of segregation produced this kind of redlining in Philadelphia. I'm using Philadelphia as an example, but I could use any city in the United States. How many of you have seen these redlining maps, again, by a show of hands, right? So you know that red meant don't lend to and therefore limit the home ownership of people who were, and here's how it was described, criminals, immigrants, and Negroes, right? If there was a concentration of those populations in a neighborhood, they would be designated as red. Fewer yellow, fewer still blue. They were developed and they were okay for lending, and green, of course, was a prime lending location, right? Now, at the University of Virginia, we had a resident scholar, William Faulkner, who wrote a lot of books. One was called Requiem for a Nun, and famous from that book was this statement: the past is not dead. It is not even the past. And so this is true with respect to Philadelphia. So if you look at a redlined map of Philadelphia in 1930, 32, 37, from the housing lending practices in those years, 1937, and you put it next to a map of Philadelphia today, you will see an uncanny parallel. So that parts of the city that were redlined where lending did not occur continue to be parts of the city today where there's concentrated poverty and disadvantage, right? And continue to be parts of the city where this may be what educational discrimination looked like in 1940 and 50 and maybe even 60. But in Philadelphia, those concentrated areas of poverty are what really continue to persist as residential segregation and deprivation today. This may have been food insecurity in 1940, 50, and 60, but it looks like this may have been criminal justice insecurity in 1940, 50, and 60. But it looks like this today. Okay, so I'm from Colorado, and on the left side, there's a map that describes black and white use of marijuana. The dark bars are black use. The lighter bars are white use. This goes through 2014. If we continue those numbers forward, they get closer and closer and closer together. But what's happening on the right side? That's arrest rates for misuse of marijuana, right? So again, what I'm trying to show is that the past is not dead, it's not even the past. Where people were redlined, they are poor. Where people were redlined, they suffer food insecurity. Where people were redlined, they suffer injustice in the criminal justice system. So what is just medicine? Just medicine is disruptive. Just medicine disrupts these patterns of legally protected discrimination. And why does it do it? Because place matters. So a deep breath now, because those were hard pictures to look at. A cheerier story, Flight 1549. How many have seen the movie Sully? All right, I'm from New York. This landed on the Hudson River. And take a look at it for a moment. There were 155 souls on board. We know the end of the story. Everybody got out. Everybody was safe. But if you look at the 155 souls on board, do you see the two groups of people that are outside of that plane? Anybody see that there are two separate groups? Just call it out. Okay, so if you ride in coach, you are on the wing of this plane, and it is going down in the Hudson River in January. That is not conducive to life. If you are in first class, you're in a raft. You've got a life jacket. You've got little rations so that if things go bad for a long time, you don't have to eat the other people on your raft for very long. You've got flares. You've got all kinds of things because place matters, right? Disruptive medicine takes account of the fact, not only, number one, that the past is not the past. It's not dead, right? So redlining in Philadelphia will describe the life expectancy rate in Philadelphia today, right? Disruptive medicine takes into account that redlining in Philadelphia in 1937, these are 4 different graphs, will describe housing and utility insecurity in 2019 today. Redlining in Philadelphia from 1937, disruptive medicine takes into account that it also talks about food security today. So we don't need people sitting at a counter in the lunchroom anymore getting tomato sauce and hamburgers thrown on them in order to have discrimination matter today. Right? We don't need people putting up signs saying, none welcome here, or you drink from this water fountain and I'll drink from that water fountain, in order for discrimination to matter in Philadelphia today, and throughout Pennsylvania, indeed throughout the country. So the evidence was gathered initially in a landmark consensus report by the Institute of Medicine. It was then the Institute of Medicine. Today it's the National Academies of Medicine. And it blamed physician bias. So here's the 2 minutes on my book. I took the bait. And I said, physician bias, that's probably what it's all about. And there is a problem of physician bias. Cultural competency is important. Training physicians to recognize when they unintentionally and unconsciously, not just physicians, nurses, physicians' assistants, radiation techs, training us to individually recognize when we group people together and discriminate against them based on their stereotypes. That continues to be important. It is part of the reason why infant mortality continues not only to be a huge problem in Pennsylvania and Philadelphia, but also continues to be a race problem, right? So that not only will 2.5 times more likely a black mother lose her baby in the first year of life than a white mother, when you control for income, and you control for education, and you control for socioeconomic status, that disparity does not go away, right? That continues to be a problem with respect to implicit bias. I am not taking that back. But just medicine depends on more than just us as individuals making changes in the way that we stereotype and think about people. It depends depends on systems and structures like Jefferson Health, like Thomas Jefferson University. It depends on the kind of innovation and reimagining that's going on here, and I have to say, I don't see often in the many talks that I give. It depends on a place that has as a mission, like you do, changing lives. So here, historically, hospitals and churches were the most segregated institutions in the country, right? This is just an example you could have found anywhere, probably in Philadelphia. White waiting room, black waiting room. But desegregation did not happen because there were hoses or dogs or marches. It happened because hospitals desegregated when the federal government wouldn't pay them otherwise. That's how desegregation happened. And what I'm suggesting to you is that hospitals, health systems, like the Jefferson Health System, like Jefferson University, is at the core of changing, disrupting, reimagining just medicine today. Look at the number of admissions that hospitals have. Look at the number of lives that you touch each year. Total admissions in hospitals, 36 billion admissions. Look at the number of dollars for the populations that need healthcare disruption the most. Look at the efficiency with which you, hospital health systems, have been able to manage much with little. You get paid 88 cents on the dollar for Medicaid. That's absurd. It's unfair. But in Medicaid expansion states, you guys are taking care of business. You're reducing the amount of uncompensated care. You're increasing the quality of care. And the outcomes are showing that you are able, as I said, to take little and make much of it. Hospitals that are managing the best are the hospitals that are in expansion states. You are the largest purchasers as anchor institutions. You're the largest employers. You are the largest influence that could collaborate with other large entities, and you could disrupt the kind of structural poverty, the kind of structural disadvantage, and the kind of structural discrimination that I'm suggesting to you is at the core of health disparities today. I'm suggesting that the disruptive way to think about it is to stop thinking at the individual level, right? I came here and I was impressed beyond measure with what you have done already. I would not be doing my job if I didn't say the vision of Martin Luther King is to go further, is to take what you've done and now bring it to a systemic level. Hospitals are the key. I'm convinced of it. Hospitals are the key. What must be done? Well, in the introduction that I was so grateful to receive, the connection between law and medicine was made. I want to suggest that in this country, change happened, not just in the healthcare system, but in every segment of society, because doctors, nurses, healthcare providers got serious about civil rights. Let me say that again. We would not have a Civil Rights Act of 1964 if it wasn't for the Medical Committee on Civil Rights that is your peers took seriously. That it wasn't just organic chemistry and anatomy and your MCAT scores, but it was how you interacted with the civil rights of the disadvantaged that made the difference. And I'm asking you to do that again. Your mission moves me, because you don't, in your mission statement, say things about how you're the best academic medical center, or we give the greatest quality of care, or we're the most famous for research. Instead, you say very simply, we improve lives. We improve lives. That means you take into account the life of the whole person. You take into account the fact that while healthcare has maybe 10% of an influence on outcomes, maybe your biology has 10% of an influence on health outcomes. It is where you live, where you work, where you play, your housing, your education, the criminal justice system that you're exposed to. You want to improve lives? I believe you have to improve lives from a perspective of equality, from a perspective of getting rid of discrimination, in all of the social determinants of health. I'll close with this picture. In Colorado, I think our national tree is the aspen. Anyway, there are a lot of aspen trees in Colorado. And each of them in this picture look like they are an individual, stand-alone tree, but they are not. Underground, a stand of aspen trees is one organism. They are connected to one another. And what I'm suggesting just medicine requires is a recognition that we, like aspens, are connected to and accountable to one another. So I commend to you, Jefferson Health, that the vision of Martin Luther King will require the health of our country to become your concern, not only from a medical perspective, not only from a public health perspective, but from a civil rights perspective as well. So thank you for your time.
You're not getting off that easy.
I didn't think so.
I think, let's see.
Okay, we're supposed to
All right,
dance.
there we
a little
go.
here.
Okay.
Okay.
So, wow. So we got to spend a half hour together. I felt like we were almost like twin kids of very different mothers. And it's interesting because your book, Just Medicine, my new book is called Unhealthcare, From Sick Care to Health Assurance, and it's very similar theme. So I want to start off with the way that I usually end my talks. And I usually end with the quote from Martin Luther King in 1966 that of all the forms of inequality, injustice is healthcare is the most shocking and inhumane. I think everybody would agree with that. And then I give the quote of Jason Kidd when he went to the Dallas Mavericks and they were 24-52. He said, "We're going to turn this team around 360 degrees." So what I'd like to understand from you, and I think you started it, but I want to really hone down. Between 1966 and 2020, there have been some advances in civil rights.
Yeah.
But there really haven't been any advances, really, in these healthcare inequities. My guess is that the 21-year difference in life expectancy between 19147 in Society Hill and North Story Mansion existed in 1965 and exists today.
Right.
So why is that?
So my argument is that the reason that is because we've seen civil rights as something over there and healthcare as something over here, and we haven't seen the connection between them, right? So you're absolutely right. We've made some advances in civil rights, but we haven't done it with the core health mission in mind as well, right? So we've made some advances in a silo. We've dealt with education in a silo, and we've tried to, Brown versus Board of Education. We've dealt with housing in a silo, and we tried Fair Housing Act. We've done these things in isolated silos, and for the most part, I'm going to be a little insulting here, for the most part, physicians, nurses think it's somebody else's business, somebody else's problem, right? What I'm asking physicians and nurses and providers and clinicians to do is to realize that to the extent that we don't take care of discrimination in housing, we're not going to take care of health disparities. We have to bring these civil rights and health missions together. I think that will help us.
So let's talk about that, because I think words matter, wording matters, and so I appreciate you understanding our mission. That was not an accident. You know, we had the same mission as every other academic medical center. We will be the premier academic medical center in Philadelphia. Other than you and your mother, nobody really cares, and you know, it depends on which upside-down Snapple award you got. So, so when we decided we improve lives, it was a fundamental change in how we were going to incent folks. Mm-hmm. It was taking advantage of the fact that this particular institution had always done a great job of taking people regardless of their ability to pay when they came to the hospital. And this was challenging us to go to the next level. But I think, you know, you keep talking about anchor institutions. Mm-hmm. And we spent a lot of time this morning talking about revolution, disruption. In some respects, I think we have to get away from that. Okay. What's an anchor? An anchor keeps you where you're at, right? I mean, so at the end of the day, the anchor institution thing is, I think some of my colleagues and some of the other universities say, look, if somebody comes to my hospital, somebody comes to my university, they get great care or they get great education. How do we start to take a place like University of Virginia or Thomas Jefferson University and really say, no, in our motto, we call it healthcare with no address. But what are some of the things that we could actually do that would get people to say, Jefferson starts at your home, in your neighborhood, in your church, in your mosque, in your synagogue, wherever you are, Jefferson or UV is there.
Collaborate. I think that's really the key word, right? So I love the idea of the fact that Jefferson has no walls, it has no limits, it's everywhere. It has to also work with everyone, right? So examples would include not just treating diabetes, but perhaps treating it along with a grocery store, a cooking kitchen, and a food education program. This idea comes to me from Brockton, Massachusetts, where a federally qualified health clinic using social impact bonds buys a grocery store in a food desert and attaches it to a test kitchen so that diabetes patients don't go one-on-one for their checkups and their care.
And that's branded as Jefferson, or you
That's branded as Jefferson, exactly. And so then Jefferson, instead of taking one person at a time, takes 8 or 10 people into their clinical checkup, writes them a prescription for good food that is culturally appropriate, shows them how to cook it in the test kitchen, and then they take their prescription next door to the supermarket, right? So Jefferson becomes a collaborator with a supermarket, with a nutritionist, and does deliver care for diabetes, but does it totally different.
and maybe uses drone technology so that the food can go from the place where Whole Foods
How
are.
could I forget the
to-
drones,
yeah,
right?
Sorry, I'm obsessed with it.
Oh, yeah?
I'm with you, good heart. So we share a blessing and a curse. You are Thomas Jefferson's university. We, for no really apparent reason, are named
just want to
Thomas
point out
Jefferson
he brought
University.
this up. I didn't bring this up.
No, but the reason, because I thought I wasn't going to bring it up, but I thought we had a really good discussion, because your president, said, all right, I think the controversy has been, and we've had, Ambassador Young here and others actually bringing this up and keeping it real, but the controversy has been, how are we going to either adore or denigrate the man, whether it's a statue or whatever. I think that misses the point, as did Ambassador Young. It puts more pressure on us, whether it's University of Virginia or Thomas Jefferson University, to do something that is totally antithetical to the negative parts of the man, but that speaks to everything that he talked about America becoming. So I'm going to sort of put a little pressure on you. By definition, President Ryan went the first step and said, I'm going to invest this money and bring in somebody of your caliber. What would you hope 5 years from now that University of Virginia is doing where people say, holy moly, I don't care what their name is or who founded them, they've really made a difference?
So in some ways, I hope that in 5 years, we're doing some of the things you've already started here with the Philadelphia Collaborative for Health Equity, which is listening to our community and letting our community drive us instead of the other way around, right? So I think that the blessing and curse of Thomas Jefferson is both that he, as a blessing, made statements about the lofty ideals of the country. As a curse, didn't live up to them. But we can. Right? We still can. We can still take we the people and mean that it does not exclude women, natives. It doesn't include only white men who pay taxes, but it includes everyone, right? We can take his dream of building a responsible citizen leadership seriously. And how do we do that? We don't separate ourselves from the community. We ask the community, what is it that you need from a resource-rich, knowledge generator like Jefferson? What do you need? What can we give you back? And we can make his dream of a country that is equal in truth a fact.
That deserves an amen. So I just want to follow up on that, because I think we all live that dichotomy that good old Tom did.
Yeah.
And I would argue that, you take our universities and our anchor healthcare institutions, and you go on any website, Dana, and it's always, what we're about. We are about community engagement. We're about diversity. We're about, taking care of socioeconomic ills. We are about innovation. Say, wow, you're president of your hospital. He must get paid based on community engagement, social determinants. Oh, no, not that. He's paid on census, EBITDA, et cetera.
Yeah.
So I think that dichotomy is something we all live. And I think, what are some of the things that we could do, that would say, oh, we're not the bad part of Thomas Jefferson. We're not saying one thing and doing another.
Yeah.
In your university and my university, what would be some symbols that go beyond just, it's easy to put something on a website?
Yeah.
Because the way I want you to think about this is I wrote a blog for the World Economic Forum. It says, Dispelling the Myth of Non-Disruptive Disruption. Because people love to say disruption, but they love to say, well, I don't want it to cause pain to anybody.
Yeah.
Well, that's like impossible.
Yeah,
So what could we do that might cause some pain to the way things were that would start to get some of this stuff
Okay,
done?
you really want to cause pain.
Yeah, I'm good at that. Anybody that works for me will tell you that right, where's Pete? Yeah, there we go. Thanks.
Okay, I'm going to start off soft and go to the
Okay.
punchline. So one of the privileges of working on Capitol Hill, I was in Debbie Stabenow's office at the time of the Flint water crisis. And my job, really I was a glorified intern, but I had some fancy title. And my job basically was to accept the calls or the visits of constituents. So America's an amazing country in this way. I can knock on the door of my senator and I can say, I'm your constituent, listen to me, and they do, right? So people exercise that influence even when they don't have dollars, they go and do it. So if you want to be disruptive, use your influence for someone other than yourself, right? So one of the things that used to make me sick to death is that when physicians and hospitals and healthcare systems came to the Capitol in order to lobby, what were they lobbying for? They were lobbying for themselves. They didn't like the electronic health records because it took too long. They didn't like the autonomy we were stealing from them. But the reason we have a Civil Rights Act is because Dr. Simpkins lobbied for his patients. He sued Moses Cone Hospital because his patients were not getting the kind of care that they should have gotten. That's why we have a Civil Rights Act. So if you really want to be disruptive, disrupt the way you're paid. And don't talk about the fact that you're underpaid and your salary is going from, I don't know, this number of six figures to that number of six figures. Talk about the fact that your patient population is disserved by the fact that medical necessity does not include housing or food. Talk about changing reimbursements so that they affect the way that people are treated in the emergency room if they've been victims of a gunshot wound, right? Talk about your patient population's needs as opposed to your needs.
All right, so last question before I bring up our student. You mentioned Solely. We actually had the co-captain of that. So I want to get into diversity and quality of the people that are leading the healthcare system. Another non-controversial topic. So you sort of hit the nail on the head. We still accept students based on science, GPA, MedCats, and organic chemistry grades. And somehow we're just amazed doctors aren't more empathetic, communicative, diverse, and creative, right? And the real tale of two cities is there are people in Philadelphia that literally spend $100,000 to get little Johnny or little Mary 5 Princeton reviews and 3 tutors so they can memorize the Krebs cycle better than somebody else. That's without even photoshopping their head on a crew member or a lacrosse player. And the gateway is still memorizing a stupid cycle.
Is it the Krebs cycle?
Yeah, very good for a lawyer. So the question I'd ask you, and the reason it gets into diversity is, so just a little fact about Jefferson. We were one of the last universities in the country to take women. We were one of the first universities in the country to accept African-American males. And we have the Boulay leaders here, and we have the Jackson Minton Scholarship. But the real dilemma has been that in 1978, 4% of matriculating medical students were African-American males. In 2018, 4% of matriculating medical students are African-American males. And a lot of it has been, look, I got new scholarships, so I'm going to get the student that maybe Penn would have gotten and give them a bigger scholarship. So 2 questions. How can we start to break that cycle and get kids that really want to go and practice and go back to their neighborhoods and do the kind of things you're talking about? Because it's going to take that. And the second thing, if you were on my admissions committee, what question would you ask a prospective student to say, aha, you get it?
So we call that a compound question in law, right? You gave me 2 questions at one time. So I think on
We call that twins in obstetrics.
I think I'll answer in 2 parts. Pipeline is the first answer that I would say. It's too late to start changing the face and color and diversity of the workforce in healthcare at the admissions to medical school stage, right? And this is the part that, again, requires healthcare providers to see themselves as members of the entire society, not just recipients of what the society has produced, because the society pipeline is very leaky. So if you want to see more African American males, if you want to see more people of diverse backgrounds, because it helps your patients, right? We have lots of data that tells us that the dyad between patients who are similarly situated culturally and ethically increases patient satisfaction. It improves health outcomes. So you have a legitimate, quantifiable, data-driven, evidence-based reason to do this. And you need to be working on the pipeline, right? You need to be working on STEM access in the 6th, 7th, and 8th grade, whether it's mentoring, whether it's bringing people to shadow.
All right, with that, let me introduce LeBaron Agostini. He's a PhD student in cancer biology and genetics. He tweets as Lee the scientist. That's okay, Lee, because I do Stevie K the DJ, so we both have alter egos. He wants to be an entrepreneur, and he has very modest goals. He'd like to cure cancer. So, you know, we teach folks to have very modest goals. He's a member of our Jefferson Business and Biotech group. So, Lee, take it away.
So I'm going to read some Q&A questions from the audience, but I'm going to take the liberty to read one of my own first. So, so the first question I have is, how can cancer centers such as ours improve clinical trial enrollment amongst minorities in our surrounding areas? Because as you spoke of, Jefferson is in the middle of the city and surrounding us as African Americans, but sometimes our clinical trial enrollments don't reflect that. So asking for some type of actionable methods that cancer centers can do in their various populations.
Yeah, cancer centers have to build trust. You have to build trust in the community, because I think if you went out and asked communities that are not enrolling whether they wanted to be a part of science or whether they wanted to be a part of the improvement in your goal to eradicate cancer, the answer would be yes, but we don't trust you. And why don't we trust you? I know we always go back to Tuskegee, and that's the seminal kind of example, but we don't trust you because you don't treat us as human beings when we get here. We don't trust you because you don't show up in our communities. We don't trust you because you don't listen to us and credit what it is that we do. In this book, one of the things I did was interview a number of women. And I know it wasn't cancer, but the number of people of color, whether it was Black, East Indian, Native American women, who said, I have gone to the emergency room, explained how I had fibroid pain and been utterly ignored. It was amazing how many women were treated that way. So why people don't trust you enough to come into your clinical trials is because you are still benefiting from and perpetuating the hierarchy that says, I'm the expert, you're not, listen to me, I'm not listening to you. People can feel that. So as you increase trust, my expectation or my assumption is that people will trust you again in the clinical trials.
Yeah, and I think in your book you say some minority patients enter the clinical encounter with suspicion and distrust. And there's a lot of reason for that. When you look at our history of research in America as it relates to underrepresented minorities and women, there's no reason to trust us.
Right,
it's a little bit like Google now with AI saying, well, of course you trust us.
Right.
We have your best interest in mind.
Exactly.
So we have to actually overcome that. Even if we're doing it equally, I think, we have to say, no, it isn't like it used to be. We have to acknowledge our past in what we did, in some cases pretty uglily, around how we handle research and clinical trials.
I think that's right.
So if you want to send me into North or South Philly to talk to communities, we can figure that out.
Okay, very good.
So I'm going to read another question. This is from Dennis Hand, a faculty member here. This question is for you, Dr. Matthew. What can urban and rural health systems learn from each other to eliminate racial disparities in health and healthcare?
I really appreciate that question because one of the things that we have done is divide to conquer, right? So the urban is different from the rural, but they're not really, right? When you talk about underserved populations and lack of access, when you talk about the improvement that technology can bring in urban communities, you are talking about the same improvement and access to care that you can bring in rural communities as well. But because rural communities are thought of as largely white and poor, and urban communities are thought of as largely black and poor, first of all, that's not true, right? That's not true. But second of all, we have this habit of separating people by color. Race is so powerful in this country, so that we shoot ourselves in the foot, where we could have the kinds of economies of scale and scope that would come from uniting the problems of these two communities and treating them together. So I love the question, what could they learn together? They could learn about ways to extend practice to the full scope of licenses for ancillary providers, right? They could learn how to use technology to bring the knowledge in a central city into the rural community, the knowledge in a university setting into the rural community. We have technology that abounds so that people could actually have real life encounters with the kind of experts that Medicaid patients don't get to because of the waiting lists that they encounter. We could do that for both rural and urban communities. And I think the list goes on, but we have to stop dividing them.
You would like to add to that, Dr. Klosko?
No, I think they're very, very different problems. I think in the urban community, it's not a matter of that we don't have the resources. We're up to our patoot in resources in a place like Philadelphia. It's that, first of all, we keep evaluating it. I am so sick of people getting money from the federal government or the state to evaluate whether or not there are racial inequalities in healthcare or, why we need population health. We've known, that 70% of healthcare has nothing to do with what happens with an anchor institution. So we were talking about this morning. If I was president, well, let's not go there. But I think that what should happen is that the federal government, when it comes to these issues, should not send a dollar to Jefferson, Penn, Drexel, or Temple to evaluate this anymore. They should put money into Philadelphia and say, if the four of you get together and actually leave your offices and go out and start to solve some of these problems around food, education, and housing, then we'll give you the money. Mm-hmm. On the rural side, I think some of it is just a matter of literally how you get the care out to where people are. I think technology has a lot more to do with that, of how can we use telehealth, how can we use some of those other things to get care out to, the fact is, it doesn't matter how equal it is. Somebody has a neurology problem and there's no doctor that can take care of it. That's a real issue. And what's interesting about that, that's global. What telehealth could mean between folks in Project Home here in Philadelphia with Jefferson is exactly what we found in Durban, South Africa, between urban Durban and 8 miles away in rural Durban by using technology. So
let me see if I can convince you that we're not saying different things, even though we've come to a different conclusion. I think we're talking about an access problem even in even in urban areas, correct, and it mirrors the rural area, right? So when we look at the quality of care that most low-income people access in an urban setting, it is the quality of care that does not have access to the multiple MRIs and the multiple CT scans, the multiple types of ancillary services and specialty services. Same problem as in rural communities. So yes, they are located here, right? But they are not accessible to the low-income population.
100% agreement. It's a physical access versus virtual access.
That's correct.
Situation. Because you're right. We have 170 MRI machines here in Philadelphia.
But try to get to one if you're a Medicaid patient.
Whereas if you're in some place in Kentucky, the closest one is 50 miles away. The maternal morbidity issue is similar.
Right.
If you're 100 miles away from a place that has a high-risk obstetrics unit, that's one issue. If you're here next to 10 high-risk obstetric units, but you can't get that access. I'll give you one example. We have an amazing, and where's Jack? Yeah, we have an amazing refugee clinic. And I always laugh because you get into some of this politics of, well, they're quote illegal. Why are you taking care of them? You're not getting paid. And I try to explain to people that it doesn't matter whether it's Democrat or Republican. The one thing about obstetrics, that sperm and the egg get together. 9 months later, they're going to have a baby. It doesn't matter whether it's a blue baby or a red baby. They're going to have a baby. And at the end of the day, the difference is it's just a practical thing. If they get no care and they show up to our emergency room at 9 months and they end up in the NICU, that baby starts out with a deficit, huge expense. If we take care of those people, and it's not a political issue, and they come in, they have healthy babies, that gives everybody a good start. So some of this is just keeping it real and giving that access to folks that is already there.
So, sorry, I just want to follow up with another question of some of the things that you're touching on as far as payment and partnerships, which is how can the healthcare system, more broadly inclusive of insurance and payers, partner with Jefferson to address some of the social determinants of health to reduce health inequality?
So I referred to it earlier just briefly, but let me expound just a little bit further. Right now, our payment system, we do what we're reimbursed for, right? And so we have siloed reimbursements whereby if I have a patient who is experiencing homelessness, I'd rather pay to have them cycle through the emergency room repeatedly instead of pay to help settle their housing issue first. If I were to settle their housing issue first, the cost of healthcare would go down, their need for substance use in order to be managing their stress would go down, and they'd comply with their healthcare. The likelihood is that their health outcomes would improve. Lots of data that tells me that. Why don't we do that, though? Because we pay for housing over here, and we pay for healthcare over there. Never the twain shall meet. So what we need to do with reimbursement is make clear that it's not only paying for somebody's insulin or paying for their emergency room visit that's going to improve their health outcomes, but also paying for their housing to be stabilized. That's healthcare. Housing is healthcare, and it's going to improve the quality of healthcare if we change our reimbursement structures to recognize that.
So as a health system, this is kind of just me right here. As a health system, how do you...
Remember, you haven't graduated yet. So.
Right. and and that last question was by Sarah. But as a health system, how do you create partnerships to create what she's speaking of here, or do we try to form independent funding resources to take care of those needs?
Oh, look, I think this is what I'd say. We get so caught up in we think that the health policy is going to solve the problem. And here's the story. It doesn't matter whether it's Medicare for All or the Affordable Care Act. The Affordable Care Act did exactly what we asked it to do. It gave a lot more people access to fundamentally broken, fragmented, expensive, inequitable, and occasionally unsafe health care delivery system, and then hope we transform. But as we were talking about this morning, there's a great quote that says it's hard to get somebody to do something when their salary depends upon them not doing it. So if you came from another planet and said, I'm gonna set up the most ridiculous health system of all time, and this is what we're gonna do. People that have jobs, they need health care, they want to keep their people healthy. I'm going to work out a system where the only people that really get paid is when you're sick, okay? And we're not going to give you any money to help keep you healthy. Oh, one more thing. We're going to totally fragment it, so even though you're the person, we're going to have your employer negotiate with the insurer, not with the hospital, with the insurer, and tell you what your insurance is. Oh, let's make it even a little bit more screwed up. Then when you go to the hospital or you go see your doctor, that's who you have the relationship. And he or she says, okay, we've taken care of you. You're going to get a bill, not from the doctor, from the insurer. And it's going to be 27 pages, and it's going to start, it says, this is not a bill, with a ridiculous number. Then, but let's get even funnier. 3 weeks later, we'll send you a real bill that has no thing with reality, that has to do with what not you, but your employer and the provider did. Oh, and by the way, if you're poor, we're going to label you. We're going to label you with a red scar. We're going to call it Medicaid. If you're old, it's Medicare. If you're old and you have money, it's Medicare Advantage, because you're Advantage. You're on that raft. So we know exactly what you are Medicaid, oh, okay, you get this care. Medicare, oh, I guess you can't afford Medicare Advantage. Oh, Medicare Advantage. So the simple fact, not that I have an opinion about this, but the issue is, despite what some folks have said, the reason we are so excited about literally partnering with Temple and Drexel and acquiring Health Partners Plan is because it's a Medicaid and Medicare Advantage plan. And the ability for us, as now the largest health system in the Philadelphia area, with the geographical spread that we have, to now start at the patient. So there is not that fragmentation. And say, patient with Health Partners, you're Jefferson. You're every bit as important to us as the CEO of a company. In fact, you're more important to us because we get to access you at home because we own the insurer. You might have IBC or Aetna, so that's still fragmented. We'll take great care of you. But you're part of our family if you're a Medicaid or Medicare patient. That's a wow. And I'll just give you one example. Jack, you know this really well. Everybody talks about the 5% that use up 50% of the resources. So we did something, and it wasn't invented by us, but we've been one of the leaders. It's called hotspotting. God, what an unusual thing. We're actually going to talk to those patients. Yeah. Who would have thought of that? And it's our nursing students and our medical students actually go out and talk to them. Why do you come to the emergency room every 2 weeks? Well, one example when I met with those students was there was a woman who had some developmental disabilities, some chronic conditions, and she had an ostomy, a colostomy. And it turns out when they really started talking to her, she really didn't know how to take care of that as well, and she knew if she went to the emergency room that they would take care of it. So $500,000 was spent, and she wasn't happy about it. Clearly the system wasn't happy about it. They started talking to her, helping her, going out to her house, texting her. She hadn't been in the emergency room 6 months. That saved the system $500,000 with healthier patients. So I think, I'll give you one other example. The Latino population, when I was up in Allentown, had the highest rate of premature labor. Some of it was culturally, that group felt that going to the hospital was sort of bad luck if you had a healthy baby. So we did, again, the unthinkable. We went out to a social center there. We deputized folks to listen to the heartbeat and measure the fundus, when you're pregnant. I took just so much stuff from the obstetricians. They're not trained, they're not obstetricians. I said, you're getting a tape measure and measuring the fundus and taking a little thing and listening to a heartbeat and counting. The fact is, and then every 3 months I made a deal with them that they would come into to the hospital. We got a good-looking Latino van driver. They came into the hospital. It's a true story, and they all came. We lowered the premature labor rate below that of the Caucasian population without spending a dime. So I think that we can't have a fragmented system where the insurers are basically incentivized to make sure that people that pay for the care, get the care, and provide the care don't talk to each other, and expect that we're going to, in essence,
I'll be even more disruptive. Because everything that you've described suggests that the real disruption lies in stopping the madness of treating healthcare as though it's a commercial good and treating it like it's a right. So if you really believe healthcare is a right of all humanity, then what you do is you look at the population's need and you meet it, with a Primodora, a community worker who can measure with a tape measure. You meet it with someone who can go out into the community and ask why you're actually coming into the emergency room. Not because it's economically feasible for you to do so, but because that is a human being, and you are servicing that human being with something they have a right to, which is an opportunity to be healthy.
Amen. Okay, we're good? We're good. All right.
Thank you.
So let me, I want to introduce, first of all, thank you, Lee. Now stay up if you don't mind, but I want to thank everyone who submitted questions from the audience. And before we conclude the event, I'm really excited to bring Merrill Torsky up on the stage. Merrill is a member of our board of trustees, the hardest working board on the planet. And she's the chair of JUICE. I'm good at one thing, which is acronyms. JUICE stands for the Jefferson University Inclusion, Community Engagement, and Diversity Committee. And she's been a passionate supporter of Jefferson. We're very proud of the fact that we're a board that really looks at this not as just, oh, by the way, but as core to our mission. So Merrill?
Thank you, Dr. Klasko, Professor Matthew, and Lee, the scientist. I wanted to get the right title there. Thank you.
Trademark that.
You trademark that, absolutely. So the Jefferson Salutes Martin Luther King's Vision is an important event on our calendar every year. The speakers that have shared their stories over the past 5 years have challenged the way we think about justice and equality, provided new perspectives, and most importantly, have inspired many of us to action. Important conversations, such as the one we experienced today, allow us to reflect on how far we have come in Dr. King's dream, as well as also recognizing how far we have to go. As chair of JUICed, I am in a unique position to witness the change that Jefferson speakers have inspired. And I look forward to witnessing the progress that we will continue to make with the insights that Professor Matthew has shared with us today. And I invite Professor Matthew to stay engaged with Jefferson as we continue to improve lives. So Professor Matthew, would you come up? This is heavy. So we are honored and pleased that you have joined us at Jefferson today, this year, for our annual celebration of Dr. Martin Luther King, Jr. and all he stood for. Please accept this award, which is an expression of our gratitude and thanks, and in recognition of your leadership, dedication, and commitment to the vision of Dr. Martin Luther King.
Thank you.
So this is presented to you today, Tuesday, February 4th.
It's beautiful.
And Lee, our scientist, soon to be Dr. Lee. We also have a little gift for you. Thank you so much.
Thank you so much.
For
Thank you so much.
Thank you so much for sharing our podium today and inspiring us with your questions and engaging dialogue. So thank you. With that, that concludes today's program. I would like another round of applause for all of our participants and most importantly, Dr. Matthew.